Dear students, welcome to E-Padasala. I am Dr. Ramamurthy, Professor and Head of the Department of Physical Medicine Rehabilitation, PSG Institute of Medical Sciences and Research, Coimbatore. For the next 20 minutes, I will be discussing with you about regulation of cardiac output. The heart is the pumping organ of blood to the entire parts of the body. By doing so, it supplies nutrition and oxygen to the entire part of the body. There are many factors governing the cardiac output, which we are going to discuss in the next 20 minutes. Maintaining adequate blood flow of blood to all the tissues of the body is the primary goal of the cardiovascular system. The heart, the cardiovascular centers, and the peripheral blood vessels all work in conjunction to achieve this goal. The amount of blood that is pumped from each ventricle is called the cardiac output. Usually, the left ventricle output through the aorta is referred as cardiac output. The amount of blood supply that is received by the different parts of the body is dependent upon the cardiac output. Hence, cardiac output is one of the most important factor in cardiovascular system of functioning. Now, we will see some definition and normal values of few names. Cardiac output can be expressed in the name of three following ways: stroke volume, minute volume, cardiac index. But in routine clinical practice, minute volume is the term used to express the cardiac output. Stroke volume. What is stroke volume? Stroke volume is the amount or volume of blood pumped out during each beat by each ventricle. Normal value of stroke volume is approximately 70 ml. It ranges from 60 to 80 ml when the heart is in beating at a normal rate of 72 beats per minute, average 70 to 8 beats per minute. What is minute volume? The amount or volume of blood pumped out in 1 minute by each ventricle is called the minute volume. It is the product of stroke volume, that is the amount or volume of blood pumped out during each beat by each ventricle, and heart rate, number of heartbeats in 1 minute. So, minute volume is derived from multiplication of stroke volume with heart rate. The normal minute volume value is 5 liters per minute. What is cardiac index? When the minute volume is expressed in relation to the square meter of the body surface area, it is called cardiac index. It is defined as the amount or volume of blood pumped out per ventricle per minute per square meter of the body surface area. What is ejection fraction? Ejection fraction is the fraction of the end diastolic volume that is ejected out by each ventricle. The normal ejection fraction is 60 to 65%. What is meant by cardiac reserve? The maximum amount or volume of blood that can be pumped out by the heart above the normal value is called the cardiac reserve. During conditions like exercise, cardiac reserve plays an important role by increasing the cardiac output. This is essential to withstand the stress of exercise and to match the demands placed in every system. Cardiac reserve is mostly expressed in terms of percentage. The cardiac reserve is 300 to 400% in normal young healthy adults. In old aged people, it will be about 200 to 250%. It increases up to 500 to 600% in well-trained individuals and elite athletes. The cardiac reserve is minimal or nil in case of cardiac disorders. Now, we will see the variations in cardiac output. Variations in cardiac output occurs in physiological variations like age, sex, body build, diurnal variations, environmental temperature, emotional conditions, after meals, high altitude, posture, pregnancy, and sleep. Similarly, during pathological variations occur in conditions like fever, anemia, hypothyroidism. Conditions causing decrease in cardiac output are atrial fibrillation, hypothyroidism, shock, hemorrhage, congestive cardiac failure, myocardial degeneration, or incomplete heart block with coronary sclerosis. Now, we will see the distribution of cardiac output. The whole volume of blood ejected from the right ventricle goes to the lungs but the volume of blood ejected from the left ventricle is distributed throughout the body for each and every system. Some organs receive high volume of blood when compared to the other organs because of a higher metabolic activity. Liver receives the maximum volume of cardiac output and heart receives the least volume from the cardiac output. Now look at the table. The table will show which organ will receive more volume of cardiac output. The liver receives 1500 ml per minute, that is 30% of the cardiac output. Next to the liver, the kidney receives 1300 ml per minute, that is 26% of the cardiac output. The skeletal muscles receive 900 ml per minute, that is 18% of the cardiac output. The brain receives 18 ml per minute, that is 16% of the cardiac output. Skin, bones and gastrointestinal tract receives 300 ml per minute, that is 6% of the cardiac output. And as mentioned already, the heart receives the least cardiac output, namely 200 ml, that is only 4%. Now we will see the mechanism of regulation of cardiac output. Cardiac output is solely determined by the product of stroke volume and heart rate. These dual factors are under control of intrinsic regulatory mechanism of the heart, extrinsic regulatory mechanism of the heart, namely neuronal pathways and its neurotransmitters, hormonal pathways and chemicals. These can be studied in detail by discussing the factors controlling the cardiac output. Now we will see what are the cardiac output and the factors affecting it. Cardiac output is maintained or determined primarily by the following 6 important factors. 1. Venous return. Number 2. Preload or afterload. Number 3. Stroke volume. Number 4. Heart rate. Number 5. Peripheral resistance. Number 6. Autonomic control. We will discuss all the 6 heading in detail. Now look at the diagram. The diagram shows how the cardiac output is controlled by neurohumoral factors, tissue factors, vascular factors and vascular anatomy. Now we will see the first important factor deciding the cardiac output, that is venous return. What is meant by venous return? The amount or volume of blood that is returned to the heart from the different parts of the body is called the venous return. Whenever venous return increases, the pressure and volume of ventricular filling increases and the cardiac output, that is left ventricular output through the aorta, also increases. Thus, venous return and cardiac output are directly proportional provided that the other contributing factors such as force of contraction, heart rate and peripheral resistance remains constant. Venous return in turn depends upon the following 5 factors, namely respiratory pump, muscle pump, gravity, venous pressure and sympathetic tone, which we will discuss one by one. 1. Respiratory pump. The respiratory activity that aids in return of blood to the heart during inspiration is called as the respiratory pump. It is also called as the abdominothoracic pump. During each inspiration, there is an expansion of the thoracic cavity and this makes the intrathoracic pressure to be more negative. The diameter of the inferior vena cava increases, resulting in increased venous return. At the same time, the descent of the diaphragm vertically downwards causes in the intra-abdominal pressure to increase and become positive. This compresses the veins present in the abdominal regions and pushes the blood upwards to the heart, and thereby the venous return increases. Respiratory pump is more efficient in several muscular exercises. So, if you see, when there is an expansion of the thoracic cage, there will be more negativity in the intrapleural pressure. When there is more negativity in the intrapleural pressure, there will be increase in the diameter of the inferior vena cava. When there is an increase in the diameter of the inferior vena cava, venous return increases. On the other side, when there is a descent of the diaphragm during the breathing, abdominal pressure increases. When the intra-abdominal pressure increases, the abdominal veins increase. When there is a compression of the abdominal veins, then there will be increase in venous return to the heart. So, second thing we will discuss about muscle pump. The muscular contraction during any activity will push the blood towards the heart. This is called the muscle pump. The veins are compressed and squeezed with muscular activity. The veins have valves that will allow only unidirectional flow of blood towards the heart only. So, during compression, blood is moved towards the heart. Whenever muscular activity is increased, the venous return will also increase. Whenever the skeletal muscle fibers contract, compression of the veins in between the muscle fiber occurs. This compression results in opening of the valves of the vein proximal to the contracting muscle. The blood will propel now towards the heart. During relaxation or when the contraction of the skeletal muscle fiber stops, the valve proximal to the veins closes and prevents the backflow of the blood. This distal valves now open and allows the blood to flow upwards. Now look at the diagram. On the left hand side, the muscles are contracting. When the muscles are contracting, the blood in the veins are pushed upwards towards the heart. The valves open and the blood in the veins are moved towards the heart. On the right hand side, you will see in the diagram, when the muscles are relaxed, when the blood in the vein will not come out because the valves allow only flow of blood towards the heart, not in the reverse direction. So, when the muscles are relaxed, blood will not flow towards the heart. Third point, gravity. The venous return is reduced by the gravitational force. Venous pooling of the blood occurs when a person stands for a long period because of gravitational forces acting on the blood vessels of the body. Because of this venous pooling, the amount of blood returning to the heart decreases. Venous pressure. Venous return is also affected by the venous pressure. In the venules is 12 to 18 millimeter of mercury. So, the pressure in the venules is approximately 12 to 18 millimeter of mercury. The pressure in the smaller veins is always greater than the pressure in the larger veins. In the inferior and superior vena cava, the pressure falls to about 5.5 millimeter of mercury. The pressure still falls, and at the junction of the right atrium and vena cava, the pressure is about 4.6 millimeter of mercury. The pressure in the atrium is dynamic and it also has a pressure of 0 millimeter of mercury during atrial diastole. This helps in filling up the right atrium. So, the pressure in the different parts of the venous tree acts as a driving force and aids in venous return. Now, we will see the role of sympathetic tone. Venous return of the heart is aided by the sympathetic tone or vasomotor tone. The sympathetic tone or vasomotor tone causes constriction of the venules. Vasoconstriction pushes the blood towards the heart. So, we have discussed so far the venous return component of the cardiac output. Now, we will see the second point of the factors relating the cardiac output, that is preload and afterload. Preload is the tension exerted on the ventricular muscle before the contraction. It is primarily determined by the left ventricular end diastolic volume. Afterload is the peripheral resistance, pressure against which the ventricle has to work to pump the blood through the aorta for systemic circulation. This is primarily dependent on the total peripheral resistance. Now, we will see what is the Frank-Starling mechanism. This can be stated as that the heart always pumps the whole volume of blood it receives from the periphery through venous return, thereby preventing excessive damping of blood in the pulmonary veins when it is under physiological limits. So, when the venous return is high, myocardial contraction will be also more, so stroke volume increases. This is explained in the graph, namely Frank-Starling mechanisms. So, in the graph it is shown when the end diastolic volume increases, stroke volume also increases. When the venous return is increased, the filling of ventricle, that is end diastolic volume, also increases. This increased preload causes the chambers of the heart, primarily the ventricle, to expand or stretch. This causes an increase in the length of the sarcomere by stretching the cardiac myocytes. When the cardiac myocytes are stretched by lengthening of the sarcomeres, the contraction force of the cardiac muscle increases. This mechanism allows the heart to effect all the additional venous return, thereby increasing the stroke volume. End diastolic volume is the primary determinant of the preload. Thus, indirectly, the length of the cardiac myocyte is determined primarily by the volume of blood in the ventricles. Frank-Starling mechanism. What is Frank-Starling mechanism? End diastolic volume, there are primarily two factors regulating the end diastolic volume. They are the duration of the ventricular diastole and the volume of venous return. This diastole interval is dependent on the action potential fired by the sinoatrial node. These contributing factors for the above mechanisms are maximum diastolic potential, slope of the diastolic depolarization, period between one SA node action potential and the other. Potassium and calcium will greatly influence the ionotrophic events and increase the cardiac output. The end diastolic volume will be less whenever heart rate increases. This is because with increasing heart rate, the duration of diastole is reduced. When the venous return starts to increase without a much increase in heart rate, a large amount of blood flows into the ventricles and the end diastolic volume will be increased. Factors that increase the contractility are called positive ionotrophic agents. Positive ionotrophic agents produce increase in stroke volume and cardiac output for a given end diastolic volume. Stroke volume is directly proportional to the end diastolic volume. Now we will see the third criteria that will increase the cardiac output. Stroke volume. Stroke volume is the amount or volume of blood pumped out during each beat by each ventricle. End diastolic volume is volume in the ventricle before ejection in milliliter. End diastolic volume is volume remaining in the ventricle after ejection in milliliter. Ejection fraction, the fraction of the end diastolic volume ejected in each stroke volume. The normal value is 70 ml. Now we will see the fourth criteria that controls the cardiac output, heart rate. Cardiac output is directly proportional to the heart rate provided that the other three factors remain constant, namely peripheral resistance, venous return and force of contraction. The cardiac output will not change with a moderate change in heart rate. If the increase in heart rate is more marked, then the cardiac output will also increase. If the heart rate reduces, the cardiac output will also be reduced. Increase in the heart rate leads to greater increase in calcium entry into the myocardial cells. This increases the force of contraction of the heart and also decreasing the systolic volume. Now we will see the next factor regulating the cardiac output, namely autonomic control. The sympathetic nervous system and parasympathetic nervous system are the feedback loops that are efferent to control the mean arterial pressure. They indirectly control cardiac output by regulating the heart rate and stroke volume. We will see what is the baroreceptor regulation. Baroreceptor mechanism control both the heart rate and stroke volume, but it will not monitor the cardiac output. It monitors the mean arterial pressure. So, when there is no change in the mean arterial pressure and cardiac output is increasing with reducing peripheral resistance, it will not respond. But on the other hand, if mean arterial pressure changes without increase in cardiac output, it gets triggered. Low pressure baroreceptors are ends of the myelinated fibers located at the junction of the atria with corresponding veins. These receptors get distended when this venous return increases. So, whenever there is fullness in the right atrium or increase in the venous return, these receptors will get stimulated and increases the force of contraction of the myocardium and increases the cardiac output. These are two atrial receptors, namely A fibers and Phi fibers, both joins vagus nerve. A fibers monitors the heart rate, B fibers monitors the atrial volume. The different axons from these receptors reach the nuclei of the medullary cardiovascular center. Increased stretch of the atrial type of B fiber receptors leads to increase in heart rate. This is called Bain-Briggs reflex. The pathways are also connected with the neurons in the paraventricular nucleus of the hypothalamus. These nuclei synthesize arginine vasopressin, that is called AVP, and this leads to diuresis and reduce the total blood volume. Atrial natriuretic peptide is released when the atrial receptors are stretched internally itself. It is a potent vasodilator and increase the renal excretion of sodium and thereby lowering the circulating blood volume and reduces the cardiac output. So, in the diagram you will see the presence of the receptors, A receptors and B receptors in the superior vena cava, inferior vena cava and right atrium medullary and other chambers of the heart also. Then chemoreceptors regulations. The heart responds to hypoxia and respiratory acidosis by increasing the heart rate. This is called tachycardia. Reduction in the cardiac output lower the arterial oxygen pressure and raises the partial carbon dioxide pressure, thereby lowering the pH. This will in turn stimulate the peripheral chemoreceptors and cause tachycardia and increasing the cardiac output. Thus, chemoreceptor senses the metabolic changes in the cardiac output. Next, we will see the last criteria that regulates the cardiac output, peripheral resistance. What is peripheral resistance? Peripheral resistance is offered by the peripheral blood vessels to the flow of blood is called the peripheral resistance. So, peripheral resistance can be recorded as the resistance or peripheral load against which the heart has to pump the blood. So, the cardiac output and peripheral resistance is inversely proportional. Resistance is offered mainly at the arterioles. So, the arterioles are called as the resistant blood vessels. In the body, the maximal peripheral resistance is offered at the splanchnic region. There are 4 factors that determine the peripheral resistance. They are radius of the blood vessels, pressure gradient and the viscosity of the blood. So far we have discussed about the regulation of cardiac output. Cardiac output is very important, so that the whatever blood pumped by the heart is taken to the entire parts of the body, which is very essential for the functioning of all the organs. So, the cardiac output is maintained or regulated by 6 mechanisms. Number 1, venous return, that is the amount of blood returned to the heart. Number 2, preload, again that is the volume of blood in the right side of the heart. Afterload, that is the peripheral resistance, that is the pressure with which the heart has to pump. Number 3, stroke volume. Stroke volume is the volume of blood comes out with each contraction. Then heart rate is approximately 72 beats per minute. The peripheral resistance, already we have seen, that is the pressure against which the heart has to pump blood. The last one, autonomic control. There are certain receptors in the blood vessels on the right side of the heart. They senses the pressure gradient and they regulates the cardiac output.